Welcome everybody to the Tissue Viability Conference. I sit as a trustee as well as a podiatrist, as the only podiatrist, I hasten to add. So my remit today was to talk around misdiagnosis of melanoma. Skin and nail. We're the supposed experts in skin and nail of the foot. And in my experience, particularly as a clinician for many years, it is that I have never come across anybody that has had that diagnosis. However, in my department, there have been 2 or 3 cases that have gone undiagnosed. So it's a life-threatening skin tumour, really, and the lesions that arise on the foot and within the nail unit can be difficult to recognise, leading to delays in diagnosis. And Ivan Bristow is a podiatrist who has a particular interest in dermatology. He produced some guidelines in 2010. Really, that's the work that we've gone from for this presentation. So they're well referenced in all our journals, in our professional journals. But the cancer arises from the pigment, the same as any other skin cancer, produced in the cell of the skin, the melanocyte. But what Ivan did, he came up with, as clinicians we're all extremely busy, and it's very easy to look over somebody's foot and misdiagnose or not even see what's going on. And I think just a point to note, it's really important as clinicians with all of us that we do look at the foot, that we inspect the foot really carefully, and especially between the toes. That's an area that can go missed quite often. And I think that Ivan came up with this acronym, which is really good for you to use just as a tool. Again, in your toolkit, as our massive toolkit is, we are very busy people, but to go undiagnosed is quite serious consequence. So it's an ABCDE. There are 2 acronyms. The A is for the asymmetry of a lesion, really like any other skin lesion. The B being irregular, ragged, or in distinct borders, so something that's not looking quite normal. I think in any case, if you see anything that you feel is a bit untoward, either to refer to a podiatrist or to the GP or through to dermatology. More than 1 centimetre in size. And more than 1 colour 6 millimetres in size and more than 1 colour in the lesion. So it's got like a speckled appearance. And the evolution of the lesion usually changes in the terms of its shape and colour. And normally the patient will not be able to explain why it has come. The other acronym is cubed. So it's any lesion that's not skin coloured, and that's difficult in some of the different skin types that we see. But once you do get to know your patients, you'll know what is right and what is wrong in their skin colour and what is indifferent. If it's an uncertain diagnosis, obviously if there's been any bleeding to the area, obviously on the foot and underneath the nail plate, the foot is always under pressure. It's under pressure from footwear and any other sort of trauma. But it's whether there's been bleeding of an unusual nature, something that's out of character. And if there's been any sort of weeping, oozing, any sort of discharge and chronic granulation, I would hope at the chronic granulation stage that it would have already been referred on to a specialist field. If the area gets larger quite suddenly, or if there is a delay in healing, beyond 2 months, they say. So it is a form of skin cancer, and it can go unnoticed for quite a long time. Certainly the cases in our department went undiagnosed for months, to be honest. And these were people who were being seen just in routine podiatry clinics. They just went along for their routine care. So how many pairs of feet do we in podiatry see? Now, this is me. Over my career, I sat down last night and worked out how many pairs of feet that I've seen over the years, and that's not a miss thing. We might laugh, but I've seen over 5.5 million pairs of feet in my career so far, and that's not including left and right, and obviously amputees we maybe don't, but that doesn't take much maths to realise that that is a lot of feet. So we need to be cautious. We can get a little bit complacent, a little bit blasé. We might be just looking at an ulcer on a foot, but not looking at the other foot. How many of us, when we're doing a treatment of one foot or leg, just take that one foot or leg off the hosiery and have a look? How many of us actually remove both socks and shoes and really inspect the feet? It is easy to do when you're time limited and you're so busy. So just err on the side of caution. Would you think these were all cancers or just foot ulcerations, necrosis? What would you think? The top right one is actually just a trauma. It's a patient that stood on a nail and that's gone into the skin. It's caused a little bit of bleeding around the periphery, and that is just a normal area. Top left is a cancer. To you and I, does that just look like some extravasation? Does it look like maybe the patient being a neuropathic foot maybe, stood on a piece of glass or had a trauma, had something in their shoe? Maybe not. That did turn out to be cancerous. I've known patients come to my clinic, one example a few years ago, and this is the extreme, but it did happen. A neuropathic patient came into clinic with a child's small toy train in the end of his shoe and didn't know it was there. So this is what you're dealing with the neuropaths as well as skin conditions. It's very complicated. Bottom left is definitely cancerous, but in appearance looks like gangrene, looks like a necrosis, looks like it could have started as something like a fungal infection between the toes. And bottom right is also cancerous. And that's difficult I was saying earlier about where it is on the foot. That could quite easily be a pressure area. The first metatarsal head is one of the prime sites of breakdown and trauma in clinics where we are with foot ulceration. So quite easily you'd think, when you look at the levels of exudate as well that are coming down the foot there, that is just pressure. I think if in any doubt, you refer on, or if you're able to, with the facilities you've got in clinic, to biopsy. My vascular surgeon I work with is forever sending biopsies off, regardless. And it's thumbs up and good news if they're negative, and if not, they're treated quickly. So the amelanotic melanoma accounts for 5%. It develops in areas where melanin is not found, so the pigment, and it can be pink, white or purple in colour. How complicated is this? It can be just about any lesion that you see on the foot. So it can be a darkened area, it can be pale, it can be pink, it can be white. So it's looking at the foot, knowing the foot, and seeing if it looks unusual. It's unusual presentation and it's not been there before. The problem is with some of the patients we see, they're poor historians. So they're not sure if they smashed a glass last week. They're not sure if they've got new shoes and they've been too tight and blistered. So you've got to try all the time to rule these things out. The right-hand picture is a picture of a heel. Now, to you and me, tissue viability, yeah, macerated, a little bit of granulation tissue, bit of overgranulation, a mixed wound, one you would treat, you'd look at the periphery and treat it just as maybe a foot ulceration with a bit of offloading, that would clear up, but actually that's cancerous as well. As is the one on the left. Now that looks like 100% granulation, a bit of peripheral maceration, a little bit of dried blood around the periphery, but again, that is a cancer. I'm scaring you all to death, aren't I? This is a local patient that was seen just recently, and she presented in clinic. Now, these are actual photos that our podiatrist took in clinic, and this lady, unfortunately, has gone on to baloney amputation because of this lesion here. And that's how she presented first off in clinic, and it's gone to the courts and lawyers and things, and it's gone to investigation, which is traumatic for everybody involved. And an independent, our vascular surgeon gave an independent view of this and said, well, actually, Jill, you know, it just does look like tinea pedis, like it's a fungal infection that's just spread coming down the foot a little bit. If you can see closely, there are some little tiny sort of raised areas, a little bit of overgranulation, a little bit of bobbling going on, but nothing that I, as a clinician either, would really think. And presented a little bit going into the cleft there, which made you think it could have been tinea pedis. That's another view of it after debridement. So again, doesn't look massively, you know, you wouldn't automatically think that looks cancerous. So it's not probing, it's not going into any depth, quite superficial. But you see the sort of warty area towards the fourth toe? That's just something that made me think alarm bells might ring a little bit. But on the whole, looks quite a healthy wound. This gentleman, again, this is one of the two cases we've had in Calderdale in the last 2 years, and for all there's not a high prevalence that they are out there. And this gentleman, it was very, very difficult for our staff. He was a car mechanic, diabetic, neuropath, and was very insistent on doing his own dressings. Would come, there'd be no dressings on, he'd have oil stuck in the wound and car bits stuck in the wound. So that was after the wound had been cleaned. But again, the periphery is unusual. It's just got that unusual look. At this point, he had a diagnosis, he did know. Unfortunately, he metastasised to his lungs as well from this lesion. But you can then see as well there, it developed into underneath the second and third toes of that dusky discoloration. And I think at first our podiatrist seen him thought it was like oil stains from being in his steel toe cap boots for hours on end, and hence maybe the maceration because he'd been enclosed in his boots for so long. He just didn't really, again like Kate's case study, didn't really take it all in. And that can be part of the battle. So then we move on to toenails. Again, they're our expertise, and again, we are supposed to be able to diagnose any abnormalities with the nail plate that goes on that is presented to us. That's our job. So again, the melanoma can sit under the nail plate, so it sits what we call subungularly. And it's typical that it gets diagnosed again at late stages. The prognosis for this can be worse than it already is, I don't know. Don't know why, but most commonly seen in the first toe. And normally the proximal nail fold is involved, so the area just towards the end of the toenail. It is thought to be due to exposure to the sun or to a trauma, which is maybe why the first toenail is normally affected, because that tends to be the toe that gets the most pressure from footwear, etc. And it can be a one-off trauma, so it could be a trauma where a cow stood on it or something was dropped on it, or repeated trauma from a tight-fitting shoe, for instance. Now, you'd probably look at that nail and think, well, that's just a bruised toenail. But is it? It isn't. That is cancerous. So that looks as though it's got a little bit of a fungal infection in. When we get the fungal infection, we get this this discoloration, this yellow, brown, crumbly nail. The nail plate's starting to get a bit friable, a few ridges on it. Nothing really but that we don't see in the 5,580,000 pairs of feet I've seen over ... years. So again, that could go missed. And again, that's cancerous. But that appearance to that nail, to me, is because it's linear, it's a different shape. If you've got a trauma, you generally get leakage of the blood across the nail plate, similar to the one before. That looks to me more like a bruising, if you like, than that one. So, but they're both cancerous. What about that one? Looks to be growing out. Looks to be growing out quite nicely. Right at the nail bed there, right in the nail bed, we've got healthy growth of nail. But no, that's cancerous also. A lot of things that happen for us in podiatry is that we would cut the nail plate back to expose. So even with subungual ulceration, where we get ulcerated nails, you'll all maybe have seen them where they're exuding from underneath the nail plate. As podiatrists, we cut the nail back. That's when we're accused of causing ulceration, because we expose the ulceration to be able to assess if the distal phalanx is exposed, and we can get dressings onto the wound bed. The nail plate is acting as a hindrance really to us, but that actually was cancerous. This lady was seen just last week in my clinic actually, a vascular patient, along myself and Kate in the clinic, and she presented a lady on oxygen, could hardly get off her scooter into the chair without having to stop and take breath. So bad. Peripheral vascular disease, really bad. Discoloured positive burgers, discoloured distal toes, and presented with this on the top of her big toe. So I called in our surgeon and said, you know, probably because I'm doing this presentation and it's there, sitting on my shoulder at the back of my mind thinking, you know, so I got him in, so I sowed some seeds with him as well and said, you know, what do you think? Could it be? So the patient's, biopsy? What do you mean biopsy? You know, she's really on the ball and, well, what's that you mean I've got cancer? She's, you know, really had to really play it down. Well, we're just going to see if there's any cell, I think he said, any cell changes. That's how he put it. So the next thing he does, bear in mind this lady's on anticoagulant as well. Without stopping the anticoagulant, gets a blade, slices the top off, pops it into the biopsy jar, puts his finger on it and walks out. There you go, Jill. So I'm stuck like with a finger in the dam and this bleeding toe, and when I did manage in the end with elevation and pressure and everything to stop it, but we're due the results of that next week. But what do you think? The jury's out. I don't think it is, but there you go. I didn't think the others really were either. So that's our lady. She's living with this not knowing as well, which they have to do, don't they? So that's a further reading. Do go and look at that, because Ivan has put up some really good pictures onto that guideline. It is dated, but unfortunately podiatry are not as involved in research as lots of nurses are. So that's it. Thank you very much. Hope I've not scared you too much.
Thank you, Jill. Are there any questions from the audience? Oh,
stunned into silence. Oh, Leanne, you are...
Thank you. I, like other members of the audience, have been caught out with these with leg ulcers. Caught out terribly dramatically, treating them as overgranulation. I put in place, therefore, because it used to be, shall we take a biopsy? Well, it was only considered if everything else were failing, we might as well do it. So from all of that learning, we've put very strict pathways in place that if you've got no improvement within 6 weeks of optimal care, we take a biopsy to make sure there's nothing sinister. I do not do that in diabetic foot clinic. Have you got such guidelines like that, or is yours a more of an ad hoc approach currently?
Yeah, no, we haven't, and you know, that is something that may be out of all this we definitely need to do, and I think, you know, probably from a national point of view, and maybe with the diabetic foot as well, because with the diabetic foot you can generally know what the etiology is, you know, by asking questions, but some patients are poor historians and they're neuropathic, they can't remember having done anything, but they do. And I mean, you can take inch-long slivers of glass out of a diabetic foot and they didn't know they'd broken a mirror sort of thing. But I do think with any foot, maybe, any foot, you know, we can put diabetics on a pedestal, and then you've got the little sweet old lady with peripheral vascular disease that goes amiss. So yeah, you know, I think it might be something you and I could work together on, Leanne, and do some national pathways. Yeah, thank you.
Can I just make the microphone on? Is it on? Thank you. Can I just come back on that, because I think it's a really good point. In the 18 years of running a diabetic foot clinic, I've seen 2 squamous cell carcinomas and 1 amelanotic melanoma, so it's actually not that common. And if we biopsied every diabetic foot that wasn't getting better in 4 to 6 weeks, we would be swamping the service for something that actually is relatively rare. But I think there are clues, so the 2 squamous cell carcinomas, the patients there was no peripheral vascular disease, they were both neuropathic, they were relatively compliant, and they weren't getting better in 4 weeks, which was the big clue. The amelanotic melanoma just didn't look like a diabetic foot lesion. It was on the foot arch, it was pink, as you say, the patient had no neuropathy, no vascular disease, no reason to have a lesion there. And the minute I saw it, I thought, this isn't a diabetic foot ulcer. Sent it off to the dermatologist with a, please biopsy this. Got sent back by the registrar saying, this is a diabetic foot ulcer. So I sent it back saying, I think I've seen more diabetic foot ulcers than you have. Please biopsy it. And it was an amelanotic melanoma.
Wow.
So I think there is that threshold that just comes with experience, actually. But I think if we wrote a pathway that said, if it's not getting better in 4 to 6 weeks, a third of my clinic would be biopsied for.
It's very useful in the venous leg ulcer cases, because you can see cholestasis in the cells as well.
Yeah.
It helps confirm your diagnosis more than just.
Yeah, and I think we know too little about the histology of the diabetic foot to make that a useful, but it's a really useful point that you sometimes find other things in the biopsy. For those of you who didn't hear that, because there's no microphone, you can actually diagnose the etiology, but I think actually in terms of the diabetic foot, the histology of that chronic inflammation, well, you probably know that anyway, because they're not offloading.
It is a difficult one, like you say, you know, they're so rare that when they do come, that's why they probably get a little bit missed, and the consequences is, like I say, with both our cases, one was a below knee and the other one was lung mets, and so what we don't want to do is miss them, but at the same time not biopsy everybody. But I think the big thing for podiatry is, and for the podiatrists in the room, is that we do, especially with diabetic feet and wounds, that we do get to know the patients really, really well. We see them week in, week out, forevermore, 20 plus years I've been seeing some of them. And so you do get to know bits about them, and you get to know their feet, and the wounds and the appearance and where they are on the foot. So on the inner arch where there's not really any pressure, but the one I showed you on the metatarsal head, that's something you would think would be just a pressure area. So very, very high. But I would say, if in any doubt, biopsy, and maybe visit local podiatry teams and involve them as well. I think it's crucial that we all work together, because for us, doing the biopsy and the lady we're awaiting the results on, that was definitely a multidisciplinary viewpoint. We both looked at it, you know, I hadn't taken a breath in, and, you know, my vascular surgeon had whipped it off with a scalpel, but that's what they do, don't they, vascular surgeons? but you know, that was a real team approach, and it was good just to have that, another pair of eyes on it as well. So if in doubt, get another colleague as well to look at it, photograph it, look at if there's any deterioration, etc., like we do. Okay, don't have nightmares, do sleep.
And I think Jill's also in an ideal position in that she's got an expert second opinion to hand, and that for the patient is good as well. She doesn't have to wait for another appointment to see an expert. So again, MDT working.
Yeah. I mean, we're using photography such a lot as well now. So, you know, if my vascular surgeon, both Kate and I, if we've seen patients and we're really unsure, not on maybe this subject, but others, that we'll take a photograph and ping it straight off to him, and he pings it straight back. Yeah, book it in, or don't we? So that's quite good as well. So a bit of technology there. Thank you.
Thank you, Jill.